All right, here we go. So yeah, you heard that right. We are going to talk about how to extubate your patient in the emergency department. And so I'm going to tell you a case I had. This was a 32-year-old gentleman who was found at the bottom of a long set of concrete stairs. And when the paramedics got there, he was GCS 3. They get him into a collar and a backboard, and they're bagging him and assisting his ventilation as they bring him in. And he's intubated for airway protection, and he gets checked out by the and he's got this huge scalp lac, so there's blood everywhere. That gets stapled up, but his FAST is negative. Then he has a pan scan, and that's negative. And in the end, we don't find anything wrong with this guy, except for the scalp lac and an ethanol level about 10 times the legal limit. Which is a fairly impressive intake of beer. And so it's possible that he fell down that staircase, but it's also possible that he just passed out at the bottom because we can't even find any bruises on him apart from the scalp lac. And this begs the question of what do you do then? You've got this guy who's now intubated, he's on a ventilator, but he's really just hammered. He's going to wake up in a couple hours and be okay. And you could consult it to ICU. But what if you work in a smaller center where you have to transfer somebody like this out? And so this brings us to the concept of extubating somebody. We don't do this a lot in the emergency department, but it's actually quite a straightforward skill. And so we're just going to run through the steps because if you can put a tube in somebody, you can certainly pull it back out. So we're going to talk about the details of this procedure, the who, when, and the how. All right. You want to select your patients thoughtfully here, right? ED extubation is not for everybody. And the first criteria I'm looking for is, were they an easy airway? As in an anatomical and physiologically easy airway. You want to know this in case your extubation goes awry. And if you need to put the tube back in for some reason, you want to be able to get the tube. So if this patient was an awake fiber optic by 3 anesthetists, they are probably not a candidate for ED extubation. The second essential criteria is that their indication for intubation has to be fully resolved. You need to be sure they no longer need this tube. And this happens to us only in a few scenarios, but some of them are actually quite common. And the ones that I've seen in my career are the patient who is intoxicated, who was intubated for that and is now awake, after a procedure. And at my place, usually this is endoscopy. So if they've been intubated so they can have GI scope them, often they're extubation candidates after that. Sometimes seizures get intubated in the field and can be extubated, or the person who you found out is DNR who now needs their tube taken out. So these are the common reasons where we might think about it. So if you have a patient who is an easy airway and their indication is resolved, you want to find the right moment to extubate them. So the first thing to think about is, has all of their sedation worn off? And has all of the paralysis, of course, worn off? You're certainly not going to extubate anybody who's still paralyzed. You need them awake and breathing. In fact, you want them so awake that they can obey for you, right? And the common test of strength here is to get them to lift their head up off the bed. If they can keep their head up for 10 or 15 seconds, that's a pretty good test of strength. You can also just give young people their phone and watch them text while they're intubated because they seem to retain that as a quite deep brain skill. You want your patient hemodynamically stable, not on 3 pressors, not in multi-organ failure, but otherwise with no hemodynamic concerns. And you want to think about their C-spine, because if you're going to extubate somebody, you want them to be able to sit up and cough. That makes it much easier for them to breathe. So if the C-spine's not clear yet, they are not a candidate. Now, these things are fairly straightforward for us to assess. We do all of those components regularly, but I want to mention 2 things here that we don't do as commonly. When I'm thinking about extubating somebody in the emergency department, the next thing I think about is, do they have a cuff leak? And what that means is, when I deflate the balloon or the cuff around their endotracheal tube, can I hear air leaking around it? And you want to hear that, right? And I'm going to tell you why in just a sec. But the way you do this is you deflate the cuff, And then you occlude the tip of their endotracheal tube and see if you can just hear a whoosh of air. Or if you want to measure this on the ventilator, you can look at, are they losing tidal volume? And you're usually looking for about a loss of 25%. Or occasionally you can listen with a stethoscope for a subtle air leak over the neck. But you want to be sure that air is moving around the endotracheal tube, because this is a key indicator that your airway is not overwhelmingly swollen. What we want to avoid is the situation where the airway is very swollen and we take out the endotracheal tube. If the endotracheal tube was all that was stenting the airway open, when we remove it, they can have acute airway obstruction, which we don't want. So when you deflate the balloon and hear that whoosh of air, you are confirming that there's space in the airway around the endotracheal tube, which is a sign that it's safer to extubate this person. So you want a cuff leak to be present. And this is an easy thing to check for, just not something that we do very often. So if you have a friendly RT, they'll typically come and do this for you. You also want to give your patient a trial of spontaneous breathing, or an SBT. And we just call it an SBT because spontaneous breathing trial is a mouthful. But this is a 30-minute, maybe a 60-minute trial of breathing on low vent settings. And so typically I'll put my patient on a pressure support of 5, on a PEEP of 5, and just have them hang out there for half an hour or so. You're looking to make sure their SAT is good, their heart rate is good, that they're comfortable. And this is quite straightforward for cooperative patients to do. If they can pass an SBT, by which I mean still be comfortable with a good SAT at the end of this, it shows they're quite likely to be successful in their extubation. And if you, as I said, if you have a cooperative patient, this is a good idea. It is harder with the patient who is perhaps less cooperative. And I find this is in my category of intoxicated patients. Some of them do not have a lot of patience for a spontaneous breathing trial, and they have a disturbing tendency to just rip their own endotracheal tubes out. Now, this is certainly one way to manage your ED extubations, but it runs the risk of damaging their vocal cords, because when you don't deflate the balloon before you pull out the tube, you can damage a cord, which can lead to permanent changes in their voice. So in my practice, there are some intoxicated patients who will not cooperate with a spontaneous breathing trial, who I will still extubate. But if you are looking for your first patient to try this on, you want to wait for someone who is cooperative enough to do an SBT. Now, if you can't remember all of these criteria, which is pretty common, there are many checklists or algorithms out there available to you. This one's from the Difficult Airway Society, but you can find a checklist for this probably from whatever your favorite EDICU blog is. There are lots of them out there. Just keep it on your phone to make sure you're not missing any of the steps. But in short, you want to be sure your patient is in easy intubation. You want their initial indication for intubation to be fully resolved. You want them alert and obeying. You want a cuff leak to be present, and you want them to have passed an SBT. That is actually the trickiest part of this, those criteria of finding your patient. We're now going to talk about how, which is really very straightforward. Are you ready? So step number 1, pre-oxygenate your patient. This is pretty basic. We do this whenever we're going to do something to somebody's airway. You do want to have your intubation gear set up and near you somewhere in case this goes sideways. That is a rare complication, but it is always better to be safe rather than sorry. Your next step is to suction the patient out. Suction in their mouth, suction down their throat around the tube, suction down the tube itself with your inline catheter. This just makes sure there are fewer secretions or mucus plugs there that your patient is going to cough out. So you're kind of doing them a favor by sucking this all out in advance. The next step is grab tight to their endotracheal tube, because you're going to hold it and control this process, and you're going to use scissors or whatever you need to cut through the ties or the tapes or remove the anchor fast or whatever is securing their tube. You're now going to release it, so you're just holding the tube in their mouth. And at this stage, you need to do a little bit of coaching with your patient. Ideally, they're sitting up, and you just say to them, hey, take a deep breath in and hold it, because you're going to pull the tube out at the end of inspiration. So you want to be sure they can take that deep breath, they're holding their breath, and then you're going to deflate the cuff with a 10 cc syringe and pull the tube out. Really easy. Once it's out, you put them on some oxygen, you suction out their mouth. So we're going to review the steps here, and then I'm going to show you a quick video to highlight this technique for you. Okay, so the basic steps, it's pretty easy. Pre-oxygenate, suction everything out, coach them to take a deep breath in and hold it. And while they're holding, you deflate the cuff and pull out the tube. Then you suction their mouth out again, and you apply some oxygen. And that really is the steps in a nutshell. It's much easier to pull one out than it is to put one in. Let's watch this video. This is from a YouTube feed called Respiratory Skills. And you can see they have their patient sitting up. They're preparing their suction gear and a 10 cc syringe. They're sucking out down the patient's throat. They're going to use the inline suction. They're using a Yankauer in their mouth. And throughout all of this, you can just be pre-oxygenating the patient by turning up the FiO2 on the vent. You then are releasing any trach ties or whatever is securing the tube, and you attach your 10 cc syringe to the balloon. When your patient's ready, you coach them to take a deep breath in. When they're holding their breath, you deflate, pull it out. Encourage them to cough while you suction out their mouth. Encourage them to take some deep breaths. Your vent will alarm there, so you can see he puts it on standby. That's a smart idea so the alarm doesn't bug you. And then you're just putting them on some oxygen, a face mask or some nasal prongs. And at this stage, you're checking in with the patient because you're looking for one of three options here. In the best case scenario, your patient is happy, they're breathing well, they don't need a lot of oxygen, and you're now going to monitor them for an hour or two, and then you're going to disposition them. Sometimes these patients are still going to need to be admitted to hospital. Maybe they were there for seizure and they need a workup, or a GI bleed and need that worked up. Maybe they were just intoxicated and they can now actually be discharged home. This is not a common thing, but it is certainly a possibility, and your patients will be thrilled. They love getting endotracheal tubes out. It's not a comfortable thing to have in place. So if you want a grateful patient, this is one of them. If your patient is not looking quite so good, as in they have a bit of increased work of breathing, maybe they're a bit tachypnic, often at this stage I will trial them on non-invasive ventilation to see if that can help with their work of breathing just as they're transitioning back to breathing on their own. The third possibility after you extubate is that your patient has laryngospasm or stridor. Be very, very careful. These are signs of acute airway obstruction. This is a patient where you want a very low threshold to just re-intubate and put the tube back in. You can try some Dex or some Epi, but you want to keep a very close eye on these people. It's not common, but you want to know what that possibility is. So for my patient who fell down the stairs, we did extubate him in the ED after we had stapled up his scalp lock, and he was thrilled. We gave him back his phone. He starts texting his friend. And in fact, he finds out that the party is still going on at the club. His buddy comes and picks him up, and he literally goes back out downtown to keep partying. For real, this was a real case. Some people are seriously immortal. All right, let's review one more time, just so we're clear on the procedural steps. Your patient's sitting up, they are being pre-oxygenated. You suction everything out, and you have a nice cooperative patient who was an easy intubation. Here they're suctioning, making sure there's nothing they have to cough. You control the endotracheal tube while you're releasing any of the ties, or in this case, he's releasing an anchor fast. Whatever is securing your tube, you take it out now. And then you're going to attach a 10 cc syringe to the balloon. Coach your patient to take a deep breath in and hold it. Deflate the balloon, pull it out. Encourage them to cough while you suck out their mouth, and you're putting them on some oxygen. That is really it. It is a very straightforward procedure and well within our skill set. The key piece here is excellent patient selection. Not all of your patients are going to be candidates for this. You want to make sure they're an easy airway and that initial indication for intubation has reversed, that they're wide awake and obeying for you. But patients who have this are so grateful. They're so pleased to have it out. Next time you have one of these patients, give it a try. It is very satisfying. Thanks so much for listening, and I'm happy to answer any questions.